Welcome. We're going to talk a little bit today about shock. Shock is kind of an interesting thing. We see it in movies, we see it in television shows and different things like that. But we're going to review really what is shock and, how should we be treating it. So shock, for the most part, is a process that leads to the eventual shutdown of all body systems. And when body systems are shutting down, they do it in a systemic order. We don't lose the heart first. We don't lose the brain first. Matter of fact, the lung, the brain, and the heart are the last systems to shut down. Everything starts from the periphery and works its way in. It is very life-threatening. It needs to be dealt with. When we talk about septic shock, the mortality rate for septic shock is still right around 50%. And so that's probably one of the worst ones. So it's really something that has to be dealt with in a very, very timely manner. Basically, what are some of the definitions of shock? One of them is, as you can see here, is we're not delivering enough blood or oxygen to the cells, nor are we moving the CO2 or any waste products. And what happens as a result of this, the patient and the body is getting much more acidotic. The more acidotic the body becomes, the worse transportation is. We're still not going to be able to move the CO2 or deliver the blood or anything else that goes with it. And what eventually happens then is we end up with cellular hypoxia and death at this particular point. We also end up with increased lactic acid, and as that increases also, it just gets worse. So what normally causes shock? What are some of the reasons for it? The one is the pump or the heart. If your heart's not working or you've had a problem with your heart, you're not going to be able to move blood or remove CO2. Another one are what we call the tubes, and these are your vascular system. And your vascular system has to deliver the oxygen, has to remove the CO2. But if the vascular system is not working, if it's too dilated, there's no way to move anything at that particular point in time. Another one is the lack of fluid. If you're bleeding out, you've lost the fluid. You're going to have all of that replaced. One of the things when we talk about hypovolemic shock is relative loss of fluid. A relative loss of fluid basically is the fluid is not where it's supposed to be. Okay? And then the last one is oxygen. What can cause the body not to be able to use oxygen or even get it? If you think about carbon monoxide poisoning, things like, or hemoglobin, things along that line, there is no way for the body to be able to use the oxygen that we're trying to give it. So there's different types of shock, and some of the major ones we're going to talk a little bit about are hypovolemic shock, and the subcategory of hypovolemic shock is actually hemorrhagic shock. You also have cardiogenic, and this is your heart. Neurogenic. Neurogenic is kind of interesting because you have spinal shock, and spinal shock and neurogenic shock are two different presentations. And it's always kind of interesting to figure out, what is going on with this patient. Anaphylactic, you guys have probably heard a lot about that. That's where people have a reaction to whatever's going on with them. Toxic shock. Toxic shock really came into its own probably in the late 90s. It was related to tampons and things like that. People would be wearing those, and then about 48 hours later, if they ended up with toxic shock, they ended up in the hospital. And unfortunately, a lot of them ended up dying, or if they did survive, sometimes they lost parts of their body. Toxic shock, though, is not limited to that. Toxic shock can also be a toxic shock-like syndrome that you can get with antibiotics and other things that we can give you. You're still going to see some of the same things we would see if you had toxic shock, but instead of calling it that, they'll say it's like toxic shock look-alike. And then, as we mentioned a little bit about septic, septic has that huge mortality rate. Every year, what's kind of interesting with sepsis, we were always trying to figure out how can we handle it. At one time, we thought vitamin C was a way of doing it, but it never worked. Another time, we thought something else would work, and it seemed to work for a little bit, and then it stopped working too. So we really still haven't quite put our finger on how do we go ahead and take care of it. And so what you're looking here is a shock combo. You don't necessarily have to have one type of shock. we can go ahead and mix a lot of different types of shock and have to treat all of them at that point. So then the causes of it are things like bleeding, loss of plasma, heart attack, heart failure, trauma, of course, or serious injury. It's hard to imagine severe pain or infection causing shock until you actually see somebody in that state. Okay, as the pain gets worse, the infection gets worse, and the infection most of the time is sepsis. At that particular point in time, we see these people going into shock at that point. We also don't talk too much about excessive sweating or dehydration. You guys know here in Arizona, we have the washes. People decide to have picnics in the washes, which is perfectly okay. Problem is you don't bring water with you. You bring your favorite alcoholic beverage. You start to drink those. It's 110 degrees in the wash. After a while, you're going to start sweating, and then you're going to become dehydrated, and then you're going to go into shock, okay? So just as a word of caution, if you're going to go picnic in the washes, especially on a warm summer day, bring lots of water with you. Allergic reactions, spinal injuries, all of those different things. Other causes could be burns, especially major burns, pancreatitis, an ischemic reperfusion injury, cardiac tamponade. We're going to talk a little bit about that. And then pulmonary emboli, depending on where they settle out, can also start to cause problems. So what are some of the signs and symptoms? Basically, you're cool, cold, clammy, you have a very weak pulse, either an increase or respiratory rate or shallow respiratory rate to go with it, a decreased level of consciousness, restlessness, anxiety, thirsty, cyanosis at that particular point. When you look at these folks, they present without what we call affect. You've lost your affect. And what is an affect? An affect is when you look at somebody, you can tell if they're happy, depressed, concerned, whatever. These folks just don't have that. And their eyes lose some of that brightness that we see with folks too. It's almost like a hazing over, so you do have to be careful with those. Decreased capillary refill is another one. Remember, capillary refill, less than 3 seconds is what you're looking for. This one is much, much longer. In some cases, you can end up with an increased, decreased jugular vein pressure at this particular point. Pulmonary edema. We don't think about shock causing pulmonary edema, but sure enough, it can. Okay. We sometimes have bounding pulses, sometimes the very weak pulses, as we talked about. Just depends on what's going on with them. And then one thing we sometimes see are wide pulse pressure in some of the early stages of shock. And if you guys remember, pulse pressure is the difference between systolic and diastolic, normally around 35 to 40 millimeters of mercury. So this is kind of a cool, most of the nursing sites have some really cool pictures, and we borrowed one from them. So some things that you see are what we just talked about. We didn't mention, but chest pain is another one. Decreased or no urine, oliguria is another one. Fainting happens with it. And you can see with this picture the early signs, the intermediate signs, and then the advanced stages, and that's where you have anorrhea, which is no urine output. Your blood pressure is dropped to the point where sometimes it's not palpable, decreased level of consciousness, cyanosis, bradycardia, all of those different things. So how do we treat shock? Well, first of all, you got to know what caused it. And if it's something that can be removed, then we can go ahead and take care of it, okay? You always have to check, make sure you have that patent airway. If they're bleeding, let's stop the bleeding. Put them in the shock position. As you can see, this person is laying down with their legs up, so you can move the blood back to the upper portion of the body. Also, their head is turned to the side, okay? And that is if they vomit, then they're not going to aspirate on it. Calm them, okay? You can talk to them. know what's going on. We're here to help you. You can monitor vital signs. Some people go, but I don't have a stethoscope. But you do have a hand, and with the hand you can take your pulse rates, you can feel the skin temperature, you can pretty well figure out what's going on with them. And then eventually you're going to end up with some fluid resuscitation. You're not going to give the patient something to drink because they're going to choke on it and aspirate. But eventually that's what's going to happen with them. There are the stages of shock. Some people will include initial as one of them. Three of the big ones that we see for the most part are compensatory. Compensatory, what happens, if you remember when we talked about flight, we talked about the fact is as you go up in altitude, you have a difference in your barometric pressure and a difference in the pressure in the cabin also, and you have an increased heart rate, increased respiratory rate. Sometimes you don't even notice it until you get higher. And as you get higher and it gets a little bit worse, now you notice that increased respiratory rate and increased heart rate. So with compensatory, with shock, we're still seeing the same type of things: increased heart rate, myocardial contractility. You're going to have some vasoconstriction because we're trying to push the blood towards the central core. If we get to you, take care of you, we can reverse it. That should not be a problem, okay? If you don't, basically you're going to end up in the progressive stage. This is where you're going to start to have lactic acid buildup, and the body becomes more acidotic with it. You end up with anaerobic metabolism. That's where part of your lactic acid is coming from. And now we're going to start to see multiple organ failure, okay? This is the systemic shutdown in the body. And then unfortunately, if we don't get to you in time, it's irreversible. The body is refractory to whatever's happening at this particular point. And as a result of it, nothing is going to work. Okay. So here's some signs of shock: and increased mean arterial pressure, but it just shows you what's going to go on and how it gets worse as you go over time. And I had some really kind of interesting tables I'm going to share with you. This one is one that I've found. If you follow the colors and you follow the lines as to where they go, stage 1, not too bad. Stage 2, we're having a little bit of difference. We're starting to see the increase in the pulse rate. If you follow the pulse, it increases until you hit stage 5, at which point in time you're going to end up losing it. And then you can see with systolic blood pressure, you're holding on to it. About stage 3, we start to see it going down. By stage 5, it's met up with the pulse rate, and it's now going down toward the lower levels. Bicarb, for the most part, we're going to use that up, but the lactic acid is about the other one that's actually going up. One of the things we see also with shock is disseminated intravascular coagulopathy, or DIC. And DIC is something that shows up a little bit late. And when it does, unfortunately, it's telling us that we're in pretty bad shape. What happens with DIC is that you have little clots. The blood begins to clot, and you have all of these little clots floating around the vascular system. If you were to go in and do a blood gas on one of these patients, they're not going to clot. You're going to have to hold it because they're going to continue to bleed, okay? You're also going to see a cytokine storm, and this is because of severe tissue ischemia, okay? And at that particular point in time, then we're going to end up with some other problems with the different molecules within the body with it. Your monocytes are going to be activated. They're going to also release some cytokines. The white blood cells are going to obstruct some of the capillaries, and then we see the DIC as it comes into it. Now, if you remember your white blood cells, they're there to help you. And that's exactly what they think they're doing when they're sending out all these messengers, and they're starting to occlude some of the passages in the vascular system. They're all trying to help us. Unfortunately, it works the opposite. So this is one, basically talks a little bit about it. If you follow the table, there's your inadequate perfusion, the cellular hypoxia. You can see anaerobic metabolism. Remember, anaerobic metabolism happens when you don't get any oxygen. All you're producing is lactic and pyruvic acid. You end up with some metabolic acidosis that causes your vasoconstriction. You're going to have some pooling of blood at that particular point. You're going to have your intercellular issues because you're going to have a dysfunction of the sodium potassium pump. And remember, your cells like to let a little bit of sodium in, but then they also want to get rid of it and get rid of the potassium so they can continue to work. And what ends up at the bottom of it is that things just get worse. So the first type of shock we'll talk a little bit about is hypovolemic shock. And as you can see, to start off, trauma injuries are a leading cause of death for individuals less than 44 years old. And you have approximately 150,000 deaths per year, and about a third of them are going to die before they ever get to the hospital, okay? And exsanguination is a major cause of death within 4 hours of your injuries, and that's your bleeding out at that particular point. So how do we save these folks? Well, first of all, you have to control the hemorrhage, and you also have to get fluid resuscitation. So with hypovolemic shock, there it is, insufficient inadequate circulating volume. This could be the plasma. You're going to end up losing your compensatory mechanisms that cannot make up for it anymore. There's your loss, relative or absolute. As I said, absolute means it's not there. Relative means it's there, but it's either in the wrong place or it's been diluted in some cases. If you're losing plasma, your red blood cell count is going up. As your red blood cell count goes up, the red blood cells get stickier. As they get stickier, they're going to start occluding the vascular system, and then you're going to end up with some issues with that too. So what are some of the common causes of hypovolemic shock? Hemorrhage is one, burns, dehydration, different things along that point. And this is just another one of those really cool pictures. And you can see you can give IV fluid replacement like blood, but you're tachycardic. I remember the first sign of hypoxemia is always tachycardia, and then tachycardia. This one is a kind of an interesting chart that I found, and this is some of your signs and symptoms that go with hypovolemia, and it tells you stage 1, compensated, all the way to stage 4, which is severe. If you look at your blood loss, less than 15%, you have compensation going on. You have to actually have that. When you get to stage 4, if you're losing more than 40% of it, which is about 2,000 mLs or more, you're in pretty bad shape at that point. And you can see with your heart rate normal in stage 1, but in stage 4, you're tachycardic. It's going to be greater than 140 beats per minute. Blood pressure, not too bad in stage 1, works pretty good. By the time you hit stage 4, it's profoundly decreased. Systemic blood pressure, less than 80. Decreased perfusion, you have to have something to push the fluid around. You also have to be able to have vasoconstriction in order for those vessels to work. At this point, when you get to stage 4, you have a lot of vasodilation, and so the blood just sits there and pools. Respirations, marked tachypnea, respiratory collapse, capillary refill is going to be greater than 3 seconds. You're going to have absent or paralytic ileus in the bowels. Don't worry about urine output because you won't have any. And you're going to be pretty obtunded. We're not going to be able to have a conversation with you. So how does hemorrhagic shock fit under hypovolemic shock, or how do the two work together? Basically, hemorrhagic shock is your rapid loss of blood, okay? Normally we see this with traumatic injuries, we can see this with surgery, even GI bleeding. People don't realize that GI bleeding is something that's pretty serious. We see this when the intensive care unit will have patients who develop ulcers. When they do, they'll start to bleed. Sometimes we can track it down and take care of them. Sometimes you can't, and you end up losing that patient. And as you can see with this too, a loss of 500 mLs of blood during surgery places your patient at risk. Now, one of the surgeries that you really have to think about is bone surgery. Because if you remember, where do your red blood cells come from? Remember, they're manufactured in the bone. And so if you're having some orthopedic type of surgery and we're going into the long bones or somewhere else where we're producing our red blood cells, we're going to be at risk for going into shock because we're losing the blood at that particular point. So who's most at risk? And I'm going to tell you, most all of these are people of age, okay? In this case, elderly folks. We don't have quite the compensation mechanism as a young person does. And so unfortunately, that sort of leaves us in a pretty bad way. Chronic or debilitating diseases, this includes AIDS and cancer, different things like that. People who have bone marrow suppression, okay, will have problems with it too. And then unfortunately, your premature or sick infants, there's not much sometimes you can do about them. You just hope for the best and try to take care of them as best you can. So what do we see? Decreased vascular tone. Remember, that's where you're going to have the pooling of the blood. Your heart's not going to work as well as it needs to. And as we said, you can also have suppressed bone marrow where you're not producing the red blood cells. Another one are your burn patients. We're going to talk about burn patients and what happens to them and how the fluid shifts with that. It goes from inside the vasculature to outside of it, and we end up losing it at that particular point. And then some other things too that you can see that can cause issues with hypervolemia shock or hemorrhagic shock. Again, dehydration, decreased oral fluid intake at this particular point, vomiting and diarrhea. A lot of people forget that vomiting and diarrhea in a couple of days, sometimes 2 or 3 days, can make you very, very susceptible to shock, okay? So if someone comes in and tells you, I haven't had any fluid for a couple of days, everything I put down is coming back up, you take a close look at them. Those people are either in shock or headed on their way to shock at that point. And there's your exposure to heat and sweating, excessive urine output. You know, if you're taking something that's going to cause you a diuretic to cause you to empty your bladder more than you need to, you can run into problems with it. DKA. I cannot stress to you how people who have diabetes really need to take good care of themselves because diabetes affects everything, okay? You've got to watch that because that's one of the major things we're going to see. So how are we going to treat all this? Find out what's going on. Stop it if you can. Do your CABs if you need to. Restore those volumes. It's going to depend on what you have, what kind of fluid. We're still debating what do we have for fluid at this particular point. We want to know what your hematocrit is because we need to know how much plasma really have you lost, okay? We're going to look at your serum electrolytes. If we don't get your electrolytes straightened out, we're going to have some cardiac issues in addition to other things with the body, the way it has to function. You may have to have some vasopressors. I know the other day I kept talking about nitroglycerin and I kept going, that's not right. I just can't quite figure it out. And it was finally I go, yes, norepi. Okay. And then because of what we're doing to treat you, pulmonary edema is something we may end up seeing. We give you a lot of fluid. The body's going to be able to use what it can, but sometimes if we give it too fast, we're not going to be able to get it to where we need it. Cardiogenic shock, if you look at this, is the most common cause of in-hospital mortality, okay, if you're having an acute MI. Some of the risk factors for this is if you've had a previous MI, if you've had previous CHF. Most people don't realize that. They think, oh, CHF, not a big deal. Put them in the hospital, give them some BiPAP, CPAP. Let's give them some Lasix. They'll be okay. Throw a couple of breathing treatments in there, and those folks will feel much better. Yeah, okay. So then there's also multi-vessel disease. You could have arterial occlusion, okay? Something else that's going on as far as that can go can cause some problems. And as you can see, approximately 5 to 7% of acute MI patients develop cardiogenic shock. Most of cardiogenic shock occurs within 7 hours in the course of your acute MI. So if you have it, we bring you to the hospital, we're taking care of you, we think you're stable, we may have taken you to the cath lab, done whatever else we're going to do at that particular point in time. Watch out, because as you get approaching that 7th hour, that's when some of this is going to start showing up. This is the same when we talk about drowning. We bring these drowning victims to the hospital. They look like they're doing okay. Everybody wants to take them home. You know, it's just a little bit of drowning, not a whole lot of drowning. And in about 7 hours, these guys go down fairly quickly. So what are some of the risk factors? Advanced age, again, your people of age. Female gender, I try to skip that part of it. If you've had a large MI, look at guys, diabetes. What can I say? Medical treatment alone, you have about a 10 to 20 chance, 30% chance of surviving this, okay? I don't want to sound like I'm the voice of doom. So other things we can see, the heart's pumping action fails, and it could be that AMI. It could also be the cardiac tamponade or a pulmonary emboli, okay, or a tension pneumo. I have some really cool x-rays I'm going to show you on people who have tension pneumos, okay. Another one could be an aneurysm or ruptured papillary muscle, okay. Mitral valve regurgitation, some of your cardiac dysrhythmias, traumatic injuries to the myocardium. Let me tell you, ruptured ventricle, you have probably a couple of moments of survival. These guys go down fairly quickly, okay? We had a friend of ours who we were working with. She was taking care of a patient. He had a stress test, survived a stress test. His EKG didn't look too bad. She got him back to the room. She stopped the wheelchair, because we used to transport our patients too. She opened the door and turned around, and he was dead. His ventricle had ruptured in that short period of time. So with this one, this shows you the pathophysiology of cardiogenic shock, and you can see all the really good stuff that happens. Actually, there's not any, but at least it shows you how all this works together. So what are some of the signs of this? Distended jugular veins, the blood is backing up. If it can't get back to the heart and it can't be pumped back out, it's going to back up. It's going to back up into the jugular veins. It's also going to back up into the vessels, the pulmonary arteries and the pulmonary veins, and there's your pulmonary edema. You're going to be hypotensive. You can either be tachy or brady. You're going to be diaphoretic, cyanosis, and you're going to have those level of conscious changes that go with it too. You can also end up with tachypnea, crackles, and frothy sputum. So this just shows you a little bit about pericardial tamponade, and you can see with this one, we have a little fluid in the pericardium. It keeps the heart from rubbing against the pericardium. Once you get too much fluid in there, though, the heart's not going to be able to pump, and that's why you're going to have that problem with getting the blood into it and the blood out at that particular point. So how do you handle a pericardial tamponade? It's really kind of interesting to watch. A lot of times, if they're trying to prove that you have one, they ask for like a 60 cc syringe, a nice big needle. You don't want the person who just came in today and goes, "Hi, I'm the new resident. I've never done this before," because what you're going to do is they're going to take this needle and put it in the pericardial sac and remove some blood. You don't want them hitting the heart, okay? And what happens with this is when you take the needle out and you look at it and you look at the syringe, the blood is not clotted. Why is the blood not clotted? Because you still have a little bit of movement going on in the heart, and that's keeping the blood from clotting. This is the kind of EKG that you actually get. When you look at this, sometimes you're going, yeah, I'm not quite sure why this looks like this. Remember, the heart's EKG, some electrical activity of the heart. This is some tiny movements of the heart, and as a result of that, we get these low voltage EKGs. I remember we got one of these, and there's 2 or 3 of us, and the doc was there. We're all looking at it going, this doesn't look too good. So a little bit about it with another one of the drawings that we get. But you can see there's the right ventricle, myocardial infarction. You see the different lead changes that you can have. And of course, you're going to go ahead and be cool and clammy because you have nothing pushing around. You may end up on mechanical vent, but you definitely have some oxygen. So how are we going to treat this? Because everything has to have a treatment. We need to be able to get your heart to work better, okay? And so some of the different things we want to do is improve your cardiac performance. We may have to intubate you, get IV access because you're going to probably need some fluid. We're going to monitor and see what's happening at that particular point, and then we're going to give you some drugs. What kind of drugs are we going to give you? Dopamine, dobutamine. If your blood pressure is low enough, norepi is something else we may take a look at too. Neurogenic shock. Neurogenic shock, how they separate a little bit from spinal shock. Neurogenic shock occurs in the cervical spine and up, okay? Most of your spinal shock occurs below that area. What can cause neurogenic shock? A head, basilar skull fracture, sometimes lower level spinal cord. Basically, you have your primary cord injury. If you don't stop it, it's going to go into a secondary cord injury, and then you're going to go ahead and end up some problems. Along with this, in neurogenic shock, you have vasogenic shock or emotional shock. Psychogenic shock also. What happens is that the person reacts to something and they end up fainting. Psychogenic shock is fainting, okay? And so we'll see that happen with this too. Some of the causes of this, we talked about the head injuries. What happens with this one, you stimulate your autonomic nervous system. You allow the parasympathetic system to take over while the sympathetic system can't do as much as it needs to. So what do we see with this? There's your massive vasodilation, decreased venous return, decreased cardiac output, decreased tissue perfusion. You're going to be bradycardic and you're going to be hypotensive. So this is just a little bit to show you spinal shock versus neurogenic shock, some of the clinical features that go with it. And just shows you that you can see with spinal shock it can last days to months. Sometimes with neurogenic shock, in about 6 weeks or so, you may actually get it back. So it's just a matter of what's going on at that particular point. So some of the clinical features we see with this, initially hypertension, a widened pulse pressure, tachycardia. As you lose your sympathetic tone, your patient's going to become hypotensive, but their skin is still going to be warm and dry, which is really kind of unusual because when we talk about shock, we talk about cool and clammy and cyanotic. However, as you lose that vascular tone and blood is not being returned, you're going to begin cooling at that particular point and become hypothermic, okay? And then because you've also lost that vascular tone, you're also going to become bradycardic at that particular point. So neurogenic is one of those shocks that you start off nice and warm and it doesn't look like anything else. So how do we diagnose this? One of exclusion. If it's not anything else, it has to be neurogenic, okay? Oxygen is something that we're going to give you. We're going to look at your airway, your vital signs, crystalloids to increase your blood pressure. Guess what, guys? We can give you dopamine, dobutamine, and if it's really bad, we can go out and get some norepi. That always works too. Atropine, a pacemaker, put you in Trendelenburg, get you some fluid, try to figure out what's going on with it. And like I said, neurogenic shock, sometimes within about 60 days or so, maybe just a little bit longer. If we see the turnaround, then we know for sure it was neurogenic. Anaphylactic shock, okay? Severe allergic reaction. This is not just that mild little thing that we have. This is something that tells us there's going to be a problem. It can be very mild to very life-threatening. The faster the onset, the worse it's going to be, okay? If it's something that shows up in 30 minutes, it's not as bad as if it shows up in 30 seconds. So we need to be aware of that. Some of the causes, medications, bee stings, sadness for the people who can't eat chocolate. Peanuts are a big one. Some of your iodine-based dyes. If you're allergic to shellfish and they're going to do a procedure and they're going to give you iodine, you may want to tell them not to do that because you can end up in anaphylactic shock. Just a matter of what's going on. What's interesting too about this, sometimes companies will change their recipes. I knew this young lady, she was a nurse, and she and some of the other folks used to eat yogurt, and they went and they bought this, whatever the brand of yogurt they were eating, and they had some issues with it. And they thought, well, that's kind of weird, but they tried it again, and they had some issues with it. And they finally called the company, and the company had changed the recipe. And because they had changed the recipe, that's why they had the problems, okay? So make sure that if you have any reaction, to chocolate, to peanuts, to whatever else, read these cartons or read the bottles or read something, because a lot of them will tell you this product is manufactured in the same plant that manufactures peanuts and everything else that you may have an issue with, okay? So they put those on the boxes for you so that you can find out and stay away from them. Sometimes, and this is one thing that a lot of people don't understand too, just because you have a one-time reaction doesn't mean you're going to react for the rest of your life. We had a student one time who was having a reaction. Doc told her, go take some Benadryl. She did. She was okay. She went and then followed up with him. And he said, you've never had this problem before. We're not sure why it happened. Probably in about 6 months, she tried the food again and didn't have a problem with it. So it doesn't mean that you cannot eat or take a medication that you used to take. It just may have been a one-time reaction at that particular point. So it's a type 1 hypersensitivity reaction, okay? Stimulation of the mast cell. You guys know the mast cell. It helps everything that's going to cause problems if you release it or degrade it at that point. What we're going to do is release some histamine. Histamine is released to call the inflammatory mediators to come and help take care of you, okay? We see the neutrophils, we see the macrophages, all of those guys show up to try to help you, but they're actually having the cytokines and they are having the inflammatory mediators also. And one of the things is if you're taking beta blockers, unfortunately, it's going to prolong whatever's going on with you at that particular point. So what are some of our signs? Massive vasodilation, hives, laryngeal edema, bronchoconstriction, respiratory compromise, cardiovascular collapse, and death if you don't treat them in a timely manner. Remember epi, just in case you're wondering, it's epi. There's some of the medications out there, they tell you, some of the ones that you use for asthma, that you have to have EpiPens. Xolair is one of them. If they're gonna give you Xolair, you have to have an EpiPen. You have to keep it with you because it's been known to cause anaphylactic shock. So here's a little hypotension, secondary to anaphylactic shock or sepsis. There you see your blood pressure going down along with cardiac output, heart rate, stroke volume, and decreased peripheral vascular resistance. We're going to see the relaxation of the vasculature. Yeah. And here's a little one. You can see it has some problems. There's your picture of your hives. If you've not had hives, they're a thing of wonder. They don't stay in one place. They have a tendency to travel. So how are we going to treat you? We're going to go through the alphabet. Instead of ABC, we're going to go CAB. Discontinue whatever the exposure is. There's your epi, further treatment, glucagon for refractory hypotension. If you're having a reaction, sometimes we will admit you to the hospital and keep you there until the whole thing subsides. You do need to go see your doctor, and a lot of times they're going to refer you to an allergist, or you can do allergy testing. There's somebody who has a wonderful reaction. Okay. Nice and itchy. You just want to go up there and scratch. Okay. So septic shock, I remember probably 4 or 5 years ago, people talked about SIRS and then going to SARS and then going to this and then going to that. And the community was sitting there going, sepsis is sepsis. It doesn't matter what you call it. Okay. Basically, it's a systemic response to some type of massive infection. We see this sometimes after GI surgery or some other surgeries that you see. Some of the risk factors for this include the extremities of aging, less than 10 years old, greater than 70, liver cirrhosis, alcoholism, diabetes are some of the issues that we see with this on occasions. People that are immunocompromised, okay? People on corticosteroid therapy, IV drug abusers are another one that we would see that too. What is this? It's basically the release of endoexotoxins, pathogens that are both positive and negative. The problem with this is we don't have the luxury to sit and try to figure out what they are. Because as you can see, you have massive vasodilation, there's your decreased venous return, decreased cardiac output, end result, somewhere tissue hypoxia, cellular death, mortality. If you want to put a number in the middle, it's right around 50%, okay? It has 2 stages, the beginning and then the end. And the warm is the beginning and the cold, unfortunately, is the end. And some of the things that you can see, there's the cytokine release. Cytokines are interesting because cytokines, there's like 1,000 different types of cytokines. So it's not just one at that particular point. There's your nitric oxide. Remember, nitric oxide is released because it's a vasodilator, okay? So if I'm increasing that, I'm getting more vasodilation. Your coagulation system, remember that's your DIC, impaired oxygen usage, all of those different things happen. And then you cannot move anything at that particular point. So some of your clinical features, fever or hypothermia, tachycardia, there's your wide pulse pressure, tachypnea, hypotension, hypoxemia, you're disoriented, problems with your eyes, vasodilation. You're going to start with respiratory alkalosis and end up with respiratory acidosis. There's 4 major ones that you see. If you have 2 of them, that's suspicion that you do have sepsis and we do have to treat you at that particular point. And it's interesting because we had a young lady one time, doc came in and said, you guys didn't do an ABG on her. We did. She was in a respiratory alkalosis. She was warm. And she was really not quite with us. And we're sitting there trying to figure out what had gone on with her. She had just gotten transferred down into the ICU. And the doc's looking at it and he's going, ooh, I think she's got sepsis. Okay. So here's some of them. The fever above 101, temperature below 96.8, your tachycardic respiratory rate, and then if you have a probable or confirmed infection, take 2 of those and you do have sepsis. And there's a case study, as you can see. Harry started off in the warm phase. His temperature went up and they had E. coli, okay? And they found it in his cloudy urine. And then unfortunately he ended up on a ventilator and his skin had turned cool and he was now in the late stage of it. So how do you present? The warm stage, early hyperdynamic response, vasodilation, cold stage, hypodynamic response. You've used up most of your compensatory mechanisms and you probably will end up with pulmonary edema. So the warm stage, massive vasodilation. You're warm, just like you are with neurogenic shock, you're warm. But this is not neurogenic shock because there's other things going on. There's your increased heart rate, bounding pulse, tachypnea, decreased systemic vascular resistance, crackles because of the released fluid. Remember, you can have pulmonary edema from this. Cold stage, we're going to go the opposite way, vasoconstriction. Now you're cool. You have significant tachycardia, but your blood pressure is down. More change in your level of consciousness. And unfortunately, there's your acidosis that goes with it too, combined. So how do we treat you? You need to treat these people fast and you need to be aggressive. And so they're going to give them some fluid to try to have something to be able to circulate. We can give you some dopamine for hypotension. We can give you some norepi. If we know what caused it, we can remove it. Empiric antibiotic therapy. Empiric means I'm going to give you something and I'm hoping to get the right thing. And so what they normally do, there's like 2 or 3 really big antibiotics out there, and they'll actually hang all of them. And then they're going to go and send for cultures to find out what's going on with you. Once they find out you don't have what the antibiotic treats, they'll take the antibiotic away. But we got to have something on board and we have to have it quickly. So that's the reason why they hang it. And this is one of the few times that we're actually going to do that. FFP for DIC. This is the letters of the alphabet. Okay, fresh frozen plasma for your DIC, glucocorticoids for adrenal insufficiency, and then we're going to give you some high flow oxygen or intubation at that point. So this is where all of this medication starts to come into play. So where does all of this come up? There you can see this is just a little table. It tells you a little bit about what you're going to see with the different types of shock. CO is cardiac output, SVC is systemic vascular resistance. You can see it's all put together in a nice little thing that you can carry with you and see what's going on with those patients. So the question is then, what's available, okay? First of all, D5W is not recommended. It leaves circulation much too quickly. We're not going to do anything about it. You have then crystalloids, colloids, and blood transfusions. A lot of times we don't do blood transfusions unless we need to and know that we can do it. Basically, if you have an estimated blood loss greater than 30% or 1,500 mLs in a healthy adult, you can transfuse 8 or more units, okay? And part of that has to do with your DIC. You also may have to give them some fresh frozen plasma to get you some clotting factors along too. So what is left? Crystalloids and colloids. Crystalloids are like Ringer's lactate, normal saline. Colloids are your HEPA starch, much bigger particles in there. The latest research basically says colloids are too expensive and they're not any better than crystalloids. So we're starting to see a lot more crystalloids. With crystalloids, you have to give 3 times the amount that you've lost, okay? So if you lost 1,000 mLs of fluid, you got to give 3,000. Why? Is because this fluid is moving in and out of the vascular system. We got to get what we can into there to keep the vascular system open to be able to transport that oxygen and remove the CO2 and the waste products at that point. And then, like I said, colloids, they're staying away from those for the most part. You don't get a much better result from it than you do with the crystalloids. If they do give colloids, they're giving, if you lost 1,000, you're going to get 1,000. And like I said, it's like your HEPA starch and things like that, much, much bigger particles. Okay. So there it is, the overall outcome of any shock. All of those go together. There's not too many things that says increased on here. Most everything says decreased. So we need to be aware of that. And then here's your shock in the respiratory system. Basically, these guys are working. When they're working really, really hard, they're going to get tired. As they get tired, they're going to start to slow down. And this also, you're starting to lose your compensatory mechanism, and this is going to help send you into shock. So one of the major things we see is ARDS. And unfortunately, ARDS has got a fairly high mortality rate too. We've gotten better, but we still have a pretty bad mortality rate in some parts of the world. A lot of tissue hypoxia. Your chemoreceptors, they're going to respond to that low pH, try to get rid of that CO2. Like I said, you're going to basically get really tired. And as a result of that, we're going to see the O2 not being available, and there's also the lack of circulating volume.